Okay, we'll move on to our next speaker. And we're going to be hearing from Laura Salgado. Let me pull up an introduction slide for her. She is, here we go, Associate Director of Neurosurgery at Elmhurst, Assistant Professor in our department. And she comes to us from Spain, where she obtained her medical degree and completed a neurosurgery residency. Came to the United States and did 2 separate skull-based research fellowships, one at Cornell and one at Northeast Albany Medical Center. And then she did her fellowship with us and has been faculty since that time a few years ago. And she's going to be talking to us today about penetrating neurotrauma. Thanks very much, Laura.
I'm going to share my slides. How's that?
Not up yet.
Okay. Forward. What about now? Can you see my screen now?
Looks good.
Okay. Thank you so much, Dr. Kellner, for that kind introduction. Good morning, everyone, and thank you for having me today. We are going to talk about penetrating neurotrauma. First, we will go over the epidemiology, classification, and management of penetrating brain injury, discussing also a couple of illustrative cases, and then we will briefly go over penetrating injuries to the spine if we have time. I have no disclosures. Penetrating brain injuries account just for 12% of all TBIs, but they carry a significantly worse prognosis. They are more frequent in the military, often caused by blast fragments from explosive devices or guns. And among civilians, the majority are from gunshot wounds to the head. Gunshot wounds are the most lethal form of all head injury, especially when they are self-inflicted. And overall, 70 to 90% of these patients with PBI will die before reaching the hospital. And half of those who reach the hospital will die during resuscitation attempts in the ED. Based mostly on the speed of penetration, they can be classified into missile and non-missile PBIs. The most common cause of missiles are bullets and shrapnel, and the most frequent examples of non-missile are knives. Missile injuries are high velocity and therefore high energy injuries, since their kinetic energy is directly proportional to the square of their velocity. They cause a kinetic injury, but also a thermal injury. And this is because they create a shock wave that will form a permanent, but also a temporary cavity that in most cases is 3 to 4 times greater in diameter than the object itself. On the other hand, non-missile are low energy and low velocity injuries that will result in focal injury along the tract of the object. Both will cause the primary and secondary injuries associated with TBI that we are all familiar with. The primary injury that will occur immediately, and the secondary injuries that will follow due to the brain edema, the increased ICP, and the decreased CPP and MAP. And since the primary injury is worse in missile trauma, the amount of edema and the ICP elevation will be also higher in this group. And consequently, these patients will have a worse prognosis, and the mortality rate will also be higher. The guidelines that we are currently using for the management of penetrating TBI were created in 2001, 22 years ago, and they have not been updated ever since. But the good news is that there's a group of experts worldwide that is currently working on new revised guidelines. And as a preview of the upcoming new PBI guidelines, one of the algorithms that will accompany them will be something very similar to this one. I know there is a lot of information in this slide, but you will see that it's fairly intuitive, and it will provide us with a workflow based on the severity of the injuries and the patient's presentations. This particular algorithm starts once the patient arrives to the ED. First, the Advanced Trauma Life Support Principles, the ABC, will take over with the primary and the secondary survey. And the first decision point is to determine the patient's salvageability, and based on the patient's prognosis and the extent of injury. The most important factors that we will have to assess here are the neurological examination, the CT and the CTA of the head findings, and the associated injury severity scores. If based on that information, the patient is considered not salvageable, he can be transferred to the ICU when the palliative care team can be consulted and the protocols to facilitate organ preservation and organ donation may be also initiated. If the patient is considered salvageable, we proceed then to the second decision point, and we have to determine the need for surgery. The new algorithm of the guidelines will likely propose two main groups here: those patients who have minor PBI and those patients who have major PBI. Minor injury will be defined as patients who have a superficial injury or a gunshot wound with a good Glasgow Coma scale and with no suspected vascular or paranasal sinus injuries. These patients may be awake and oriented, and maybe they may not even require surgery, maybe just some bedside debridement and suturing, but others may require a more extensive debridement in the OR. In all cases, they will most likely eventually proceed to the ICU for observation, but they won't require major additional critical care. The major injury pathway, on the other hand, will be defined by patients with significant PBI, with possible injury to multiple lobes, midline sheath, protruding foreign objects like knives, and high suspicion of a traumatic or vascular or sinus injury. Some of these patients may not need surgery immediately, and they can be transferred to the ICU, which will likely be rare in a patient who is considered salvageable and have major injuries. But most of these patients will require to go to the OR. And if they go to the OR, then a CTA stat is very important. Although it's not the most sensitive study for the diagnosis of vascular injury, it is a quick diagnostic tool, and it can give us a very good picture of a neurotraumatic injury such as an aneurysm. If the CTA shows large, deep traumatic aneurysm, and if the patient can't tolerate it from an ICP and an intracranial standpoint, it may be necessary to do a diagnostic and potential therapeutic angiogram before going to the OR. This may be helpful, as it may be very challenging to control a deep arterial bleeding in the section of a significant brain swelling, tissue disruption, bone fragment, 4-inch bodies. Once the CTA is done, some of the surgical recommendations will be to perform an early decompression with repair of the skull base, the sinus injuries, mostly to prevent also from a CSF leak and an infection. Do not wait for a patient to deteriorate or to have midline shift to operate. And do not wait to repair a CSF leak or a skull base or a sinus injury. Some 4-inch bodies that are superficial and easy accessible should be removed. And if there is an external protruding object, it should be removed as well, but in the OR, never outside the OR. And we are going to review now in more detail some of the specific aspects of the PBI management algorithm. And we will do so by discussing at the same time a case that we have here at Elmhurst early this year. In terms of the initial management, early aggressive treatment of the hypoxia with intubation if needed, the hypotension is key. We always have to look for other extracranial injuries and of course, follow spine precautions until we can rule out spine injuries or instability. Our case was an 18-year-old male with no significant medical history who was brought to the ED after sustaining a gunshot wound to the head. He was already intubated. He was hemodynamically stable and had no other extracranial injuries. Upon arrival to the ED, his GCS was 3, same as prior to intubation on the field, and his pupils were small and minimally reactive. And the other brainstem reflexes were absent in the context of sedation. And he had 1 bullet entry wound in the right retroauricular area. Some of the most important aspects of our initial neurological examination of these patients will be the GCS, especially the best motor response, which has been independently associated with the patient's prognosis, and the pupillary reactivity. We should also assess at bedside the entry and the exit wounds, if there is any noticeable CSF leak or exposed dura or brain, and if there is any protruding object, in which case we will have to stabilize them before trying to remove them in the OR. If we are dealing with a gunshot wound of the head, we have to assume that the ICP will be high. And then we can start treating them from the moment we see the patient, just by making sure that the head of the bed is from 30 to 45 degrees, and also by giving empiric hyperosmolar therapy. And mild hyperventilation in these patients is also recommended. And for most of these patients, we will also have to give tetanus prophylaxis. In terms of antibiotics administration, there is an overall agreement that patients with PBI may benefit from antibiotics, and therefore they're usually recommended and given. But there are no control studies or consensus on agent or duration. And the most common reported times in the literature vary from 1 to 10 days. There's a systematic literature review that was published in February this year that it failed to reveal significant benefits on antibiotic administration in PBIs. Although the authors, based in their own institutional series that also published, suggested that patients may benefit from a short course of prophylactic antibiotics. We usually here at Elmhurst advocate a course of broad spectrum antibiotics for about 7 days. And in terms of seizure prophylaxis, we have to be mindful that PBI may have it has a high incidence of early and late post-traumatic seizures. Both Keppra and fosphenytoin can be used. Based on the available literature, there's no significant difference in their efficacy of preventing seizures for PBI, and they both have been shown to reduce the incidence of early but not late post-traumatic seizures. And again, there's no really a consensus on the duration of the treatment or prophylaxis, but most of the studies recommend at least 1 to 2 weeks. Let's talk now about that initial imaging, the CT and the CTA of the head. Non-contrast CT will be our primary imaging for PBI. It is quick and it will allow us to identify potential bone fragments or forage bodies. One of the disadvantages of this modality technique is the significant artifact that we can encounter if there is any metallic fragment. Same as we have all seen sometimes with the aneurysm clips. Things that we must look at are the missile trajectory. If it crosses a vascular territory and there's a potential vascular compromise. And of course, we have to look at the overall extent of the brain injuries and if there are any intracranial hematomas, and if those hematomas are causing mass effect. In our case, the initial CT head show bullet on the right preterus bone and a subdural hematoma in the posterior fossa that it was causing mass effect on the underlying cerebellum and brainstem. Up to 30% of all patients with PBI will have a vascular injury, and it goes up to 50% of gunshot wounds. We can encounter traumatic aneurysm, dissections, occlusions, thrombosis, or even a spot sign that indicates active hemorrhage and at the time of the scan. And the same that we can see on non-traumatic ICH, and it will correlate with a worse prognosis. CTA is usually acceptable acutely in most cases, but we cannot rely on this as a sole method to rule out traumatic aneurysm. And an angiogram may be needed in most cases. It has less artifacts and better resolution, but it will require more time and resources. In gunshot wounds, most of the times it may need to be delayed because of the immediate need for surgery. And given the high incidence of vascular injuries in this particular group, a second angiogram can be useful around week 2 to also detect some delayed vascular complications such as AV fistula. Because non-missile objects usually result in less brain injury, there is often time to do an angiogram before the surgery. And we should try to do so, especially if there's high suspicion of a vascular injury, such as these cases where the bullet crosses, sorry, not the bullet, the non-missile object crosses the skull base or a dural sinus, or there's any evidence of arterial bleeding in the CT head. In our case, the initial CTA that you can see here, it showed an occlusion of the right transverse sigmoid sinus. And remember the algorithm of the upcoming guidelines. All these initial pieces of information that we just have reviewed in more detail have the purpose of helping us determine the patient's salvageability and the overall patient's prognosis. So with that in mind, which one are the main prognostic factors for PBI? Most of the studies have found that the level of consciousness is the most important prognostic factor. The motor component of the GCS score has been shown in several studies, together with the pupillary reactivity, to be independent factors and the stronger predictors of survival. Regarding the missile trajectory, poor prognosis is associated with crossing the Z and the X, the midline, the ventricles, and important brain centers such as the thalamus, or multiple lobe injuries. Large intracranial hematomas and the lack of patency of the basal cisterns have shown also association with higher mortality and worse prognosis. And likewise, self-inflicted injuries and male gender, high injury severity scores, and INR have been linked to a worse prognosis. Time to surgery. Several US military associations published a paper a few years ago on patients with severe combat-related PBI who underwent decompressive craniectomies. And they found that the post-operative mortality was significantly lower when the surgery started within 5.5 hours of the injury. So in summary, who's not a good surgical candidate? Patients with fixed and dilated pupils, comatose patients with a transventricular, transencephalic, or brainstem missile trajectory, those who have an uncontrollable extracranial bleeding, hypotension after full resuscitation, or an uncorrectable coagulopathy. Overall, we are going to follow similar surgical principles to close TBI. We have to keep in mind again that PBI carries a worse prognosis. And every particular case, the management should be individualized. And here are some specific surgical considerations for measles PBI. Once the patient is considered salvageable, surgery usually needs to happen fast. The goals of surgery will be ICP control to prevent and even try to reverse cerebral ischemia and herniation. And surgically, we will do so by evacuation of any surgical mass lesions, such as extraaxial hematomas, and by performing decompressive craniectomies. They can be either unilateral or bifrontal, depending on the location and the extent of the intracranial injuries. Another ICP measure would be CSF diversion through an EVD, which will be also helpful for ICP monitoring. Local debridement is another surgical goal. We have to take care of the scalp, both the entry and the exit wounds. Brain tissue, especially if it's non-eloquent. I try to remove any accessible bone fragments and bullet fragments, which will also be helpful from a forensic perspective. And additionally, we have to cranialize any air-involved sinuses, aim, if possible, for a watertight dural closure, and try to obtain a good hemostasis. In our case, the patient underwent emergent suboccipital craniectomy with C1 laminectomy, evacuation of the subdural hematoma, and placement of an EVD and intraparenchymal bolt monitoring. Patients with non-measles PBI usually have a better prognosis, and therefore they are more often salvageable and considered surgical candidates. Since these lesions are more focal and there's less edema and high ICP, surgery is often less emergent, which is good because it will give us time to perform preoperative angiogram, which often is critical for operative planning. Goals of surgery will be very similar to measles PBI, but non-measles surgeries are more focused on the careful removal of the embedded penetrating object. The craniotomy will usually be created around that entry site, and it's important to open the dura prior to try to remove that object to have direct vascular control and to perform good hemostasis. And if we already suspect a vascular injury, some dissection and proximal control should be obtained prior to try to remove the penetrating object. Once we complete the operative management, the patient's care will continue in the ICU, where the post-operative management will be largely dictated by the recommendations provided by the 4th edition of the Brain Trauma Foundation guidelines. PBI have potential for multiple early and late complications, such as vascular injuries. One of the most frequent ones will be traumatic aneurysms, especially on high velocity measles, or in those cases where the trajectory of the object crosses a vascular territory. Sometimes they can be found as an incidental finding on the initial or repeat CTA, but they can also debut with a large or delayed hemorrhage. Another complications are early or delayed CSF leaks, especially when there are multiple scalvis fractures or air sinus injuries. They can be exacerbated by hydrocephalus, and ultimately they may need endoscopic or open surgical repair. In our case, repeat CTA that it was done on day 10 show like a 5 millimeters pseudoaneurysm, and the patient underwent the next day successful aneurysm embolization. Infections are among the most common complications in PBI, and that's why antibiotic prophylaxis is widely accepted in these cases. Those patients who eventually will need to undergo cranioplasty will generally do so in a delayed fashion to reduce this particular infection risk. And another common complication is hydrocephalus with the potential need for prolonged CSF diversion or a definitive shunt placement. In our case, the EVD and the bolt were removed on the second week of admission after a successful clamp trial, and the patient underwent trach and peg on week 3. Unfortunately, on week 5, the patient developed fevers, and a CTA of the abdomen revealed an abdominal pus wall collection around the peg, and he underwent peg removal with surgical debridement, and he was also started on antibiotics. The patient also developed pseudomeningocele and ventriculomegaly that were progressively getting worse. So eventually, around the same time, the lumbar train was also placed. Once the patient was cleared from an infectious standpoint, he underwent ventriculoatrial shunt placement. 1 month after the shunt, however, he developed worsening hydro, and the distal catheter was found to have migrated to the left axillary vein. So he underwent shunt revision and conversion to a ventriculopleural shunt. And he eventually was discharged to acute TBI rehab. We actually saw him in clinic yesterday, and he's currently oriented ×3, he's following commands, and he can ambulate with aid. And we are going to discuss now 2 different cases. They were both published in the Journal of Neurosurgery in 2017 and 2020. Both have very similar type of penetrating brain injury, but will differ substantially in terms of management and outcomes. The first case was published by a friend of mine, was my senior resident back in the day. A 3-year-old boy with a hyena bite to the skull that was transferred to the ED 1 day after the injury from a local dispensary in East Africa. He was found to have a large deglobing wound with herniating brain and a mild subarachnoid hemorrhage. He was GCF 15 with no focal deficits, and he was taken to the OR 1 day later for wound debridement and duroplasty using his own percranium. But unfortunately, due to the amount of lost tissue, the skin defect couldn't be closed. The patient developed a CSF leak that it was treated with Diamox and dressing changes. 2 additional unsuccessful surgical attempts were made to close the skin and repair the dura. He was found to have, on a repeat CT head, ventriculomegaly. However, there were no available EVDs or lumbar trains. Multiple cultures were obtained, but they were not eventually processed due to the costs. No further surgeries were offered by the plastic team due to the procedure's complexity. And by the 4th week of admission, the patient developed meningitis, severe hyponatremia, and eventually died. The second case is a 9-month-old boy with an American bulldog bite to the skull that it was transported by air ambulance to a pediatric trauma center in Colorado. He was found to have, again, a large deglobing wound with herniated brain, and also multiple transected M3 and M4 branches with active extravasation, as well as a subdural and intraparenchymal and intraventricular blood. He was taken immediately to the OR for a decompressive hemicrania. The scalp defect was covered with duramatrix onlay and alloderm. On note, during the surgery, he went into cardiac arrest due to the profuse bleeding, but he was successfully resuscitated. The patient underwent multiple surgical interventions over the next few months, including 3 EVD placements, surgical debridement and washout of the wound in 2 separate occasions, ventriculoperitoneal shunt placement and revision, and 5 months after the attack, a split thickness graft surgery with the idea of a free flap cranioplasty when he gets older. His skin flap healed well. On exam, he had left hemiparesis and mild developmental delay, but he could ambulate and communicate verbally. And based on the initial presentation and the extent of the intracranial injuries, I would have argued that under the same circumstances, the first case that happened in East Africa would have had a better outcome than this second patient. Africa accounts for 15% of the global volume of the neurosurgical pathologies, but it only has access to 1% of the neurosurgeons worldwide. On the Africa continent, the regional inequalities are also significant, with 73% of the neurosurgeons working in Africa practicing in the north and south. In East Africa, the ratio of neurosurgeons is 1 per 10 million of people. The first pediatric case that we discussed today was treated at the Majembili Orthopedic and Neurosurgery Institute in East Africa, Tanzania, one of the 2 centers in the peninsula that provides neurosurgical care for more than 70 million people. Additionally, there is 1.8 million people that live in the islands, in Zanzibar, that have to face a long distance and limited transportation resource to get to these referral centers in the peninsula. And no neurosurgeon had ever practiced in the islands until the Neurosurgery Education and Development Foundation arrived in 2008, which was just like 15 years ago. So the patients before with neurosurgical conditions were the vast majority of the times not getting any treatment. This project started with short-term surgical missions carried out by volunteers, and in 2014, they built this neurosurgical institute that is known as the NEED Institute. The first case that we discussed also highlights some of the of practicing neurosurgery in a low resource setting. First, the scalp reconstruction couldn't be performed due to the lack of resources, experienced plastic team. Specific cultures were eventually not obtained due to costs. And third, CSF diversion could not be performed due to the lack of a lumbar train, EVD, and collection bags. The team there was also hesitant to use a shunt proximal catheter, since hydrocephalus is the most common neurosurgical treated disease, followed by TBI. So another patient could have benefit from using the full shunt system. And also the ICU at the time was the only place where the nurses were trained to manage the EVDs, where it was full with intubated TBI patients. The local providers there and the society have a different understanding of the value of time. There is a Swahili expression, polite play, which translates as slowly, slowly, that embraces their lifestyle and philosophy and the avoidance of rushing to do things, which unfortunately in medicine results in significant delays in patients seeking treatment, but also initial assessments where they arrive to the ED, transfer, and ultimately medical and surgical treatments. Some additional resources that have been used in the past for similar cases with better outcomes are transferring the patients to a better equipped setting, sometimes even to a different with help from the national embassy, visiting medical teams that have the expertise needed to do more complex cases, and they can even bring their own equipment and supplies, such as in this case, for example, a Europe substitute. Engagement of philanthropies and charity organizations, such as mosques or churches, and by promoting education of and training of the local providers and also the society on basic health knowledge and also health seeking behaviors. This is a model of international health cooperation described by the Knee Foundation, which has guided their different interventions over the last 15 years, promoting global neurosurgery. This model has simultaneously aimed to intervene in 3 different areas: equip, treat, and educate in a stepwise manner, identifying different levels of complexity, 1, 2, 3. When interventions are applied simultaneously in these 3 areas, which constitute the major gaps in low-resource healthcare systems, they have a greater impact, and they facilitate a gradual increase in the autonomy of the local providers, with a gradual reduction for the need of external support. And we're gonna move now to briefly try to go through penetrating injuries to the spine. Annual incidence of a spinal cord injury in the US is just 50 cases per million, and penetrating spinal cord injuries is just the 15% of them, the 3rd most common cause. And they, however, carry significantly higher morbidity and disability rates, and up to 1/3 of the patients will have another concomitant non-neurological injuries, mostly in the abdomen and in the chest. Penetrating spinal cord injuries have a higher percentage of patients covered by Medicare or uninsured. The injury severity score on admission and the hospital length of stay are also higher, and even a higher percentage of these patients are males, 88.9%, and the population is even younger, 29 years old on average versus 43. And instead of the cervical spine, the thoracic spine is the area most frequently involved. We can classify them in a similar manner than penetrating brain injuries into mesial and non-mesial injuries. Mesial injuries carry by far a more...
Laura,
Yeah.
you gave such a good talk. You know, you're going to have 0 time for any discussion.
Okay.
Don't you think it would be better to, you know, you come back and we'd be happy to hear the thoracic part.
I agree.
But you covered so much ground. You went from science to world health, philosophy. It was a beautiful presentation, frankly, and very sophisticated. So just give a moment for question about some of the things you've said, and be happy to have you talk about spine in another time.
I agree. Thank you.
So who has comments? We could discuss what she spoke about from 100 different angles.
Dr. Salgado, thanks so much for providing the update about that patient. I remember that patient. We took him to the OR together. It's I just want to comment that it's really great to hear that he's able to walk, because he came in to us at that store. So it's amazing.
Thank you, Ray. Yeah, he's able to walk. He's starting to eat. Soft texture, and he's doing trach caps.
Wow, I'm so happy to hear that.
Do you get any mesial injuries? Do you get a high number of mesial injuries? Do you see that anymore, Laura, at Elmhurst? Or is it just the regular lower acuity gunshot wound, which can be pretty bad on their own?
Since I'm here, honestly, I have just seen 2 cases, and they were both gunshot wounds, non-mesial, high energy. I don't know, Sachs had more experience than I do, and has been here longer than I am, so maybe he thinks differently.
We get a couple a year. We get a couple of gunshot wounds to the head a year. It's definitely, there's been an uptick in overall gunshot wounds, even extracranial, as well as cranial and spine, since COVID, actually. And that's kind of been seen throughout the United States. But yeah, we certainly not as many as we got when I was in Miami, where we had a couple a week, unfortunately. I think one of the biggest, you touched on it, but I think one of the biggest things that's going to come out of the new updated guidelines is a high focus on the cerebrovascular injuries. And in particular, while we utilize CTA as a screening tool, really focusing actually on angiograms in a lot of these cases, because there's quite a fair amount of data out of the military, both with blast injuries and shrapnel injuries, that CTAs can and do miss some of the injuries that we see, because some of them can be pretty subtle, and then also delayed, making sure that all these patients get follow-up angiograms, a week out or so, and then if they still have an injury, or they have an injury that develops following them long term, because they typically will change, some for the worse.
Okay, well, we're reaching the end. To me, the most moving part of what you spoke about, in addition to the individual patients, was the contrast between how annoyed I was getting yesterday waiting 7 minutes to re-update my transverse sinus heads-up display, and the neurosurgeon who has 70 million people in his group that he has to treat. So it's good to keep those things in perspective.
And definitely.
Pole, that's a great sign.
Thank you so much. Thank you so much, everyone. Yeah, it's been more than a year since I started here at Elmhurst, and I couldn't be happier or more grateful. Thank you so much.
Same with us. Okay. Thanks a lot, everyone.